Welcome to Module 11, Wound Complications and Red Flags, a critical part of our wound care series. Imagine this. A wound that looked stable yesterday suddenly appears angry, swollen, and leaking foul-smelling fluid. As clinicians, we've all had moments like these, where a wound takes a turn, and we're left thinking, could I have caught this sooner? This module is about making sure the answer to that question is always yes. We're going to explore the key complications that derail healing, and more importantly, how to catch the red flags early and act decisively to protect your patients. By the end of this module, you won't just know what complications exist. You'll know how to spot them, interpret them, and take action. Specifically, you will understand common local and systemic complications that interfere with healing. Learn to identify red flags early, sometimes before visible signs emerge. Grasp the underlying pathophysiology of complex conditions like necrosis, osteomyelitis, and biofilm. Know when and how to escalate care, be it to a wound care specialist, a physician, or for hospitalization. And finally, you'll recognize how effective documentation isn't just paperwork. It's clinical protection for you, your patient, and your team. Remember, recognizing complications early can literally be life-saving. Wound healing is supposed to follow a structured journey: inflammation, proliferation, remodeling. But in real life, that journey often hits detours, complications like infection, tunneling, or necrosis that stop progress in its tracks. Think of wound care like flying a plane. Everything can be going smoothly, but a storm, like infection or dehiscence, can suddenly appear on your radar. And if you're not alert, that storm can spiral out of control. As nurses, you are the first radar system. You're the first to see, touch, smell, and assess that wound. This module will help you develop clinical instincts so that when the wound starts whispering that something's wrong, you'll hear it before it starts screaming. Let's walk through some of the most important complications in wound healing. These are the ones we see often in clinical practice. Infection. Whether it's surface level or systemic, it leads to inflammation, cell death, and impaired healing. Biofilm. This is like a protective bubble of bacteria, making them resistant to antibiotics and hard to remove. You can't see it easily, but it's a major cause of chronic, non-healing wounds. Necrosis, or dead tissue. It's a breeding ground for bacteria and acts like a physical and biological barrier to healing. Dehiscence, especially in surgical wounds, where the skin or fascial layers pull apart, often due to poor suturing, infection, or pressure. Undermining or tunneling, wounds that look small on the surface but extend deep underneath, harboring bacteria and fluid. Hypergranulation, when granulation tissue grows above the wound bed, preventing epithelialization. Osteomyelitis, infection that reaches the bone, often requiring long-term IV antibiotics or even surgery. Fistula formation, when a wound creates an abnormal tunnel to another organ, like the bladder or bowel. Chronic inflammation, the wound gets stuck in a cycle of destruction instead of repair. Each of these is a red flag, and your job is to catch them before they escalate. Now, let's talk about what the wound is telling you, if you know how to listen. Here are local red flags that mean something is going wrong. Rapid increase in wound size suggests hidden infection or tissue destruction. Color changes, pale, that's ischemia. Green, possibly Pseudomonas. Black, that's necrosis. Bleeding, especially new or persistent, could indicate trauma or a vascular problem. Heavy, purulent exudate, a sign that bacteria are multiplying faster than the immune system can keep up. Foul odor, anaerobic bacteria at work, always a bad sign. Sudden or worsening pain, especially in a wound that used to be painless, often signals infection or necrosis. Rolled wound edges, called epibowl, indicate a chronic, stalled wound. Sinus tracts or tunnels. These hide infection deeper inside. Poor granulation, fragile or absent tissue may indicate malnutrition, infection, or poor perfusion. Clinical pearl. If a wound doesn't reduce in size by at least 30% in 4 weeks, it's not healing properly. Reassess your plan. Don't just look at the wound, look at the patient. A wound may be small, but if systemic signs are present, it could be far more dangerous than it appears. Systemic red flags include fever and chills, classic signs of infection spreading beyond the wound. Tachycardia or tachypnea may signal sepsis or systemic stress. Altered mental status, especially in older adults, can be the first sign of sepsis or metabolic imbalance. New or worsening edema often signals poor lymphatic or cardiac function, or inflammation from infection. Fatigue, malaise, non-specific, but when paired with local signs, take them seriously. Pain with elevation, a subtle but important clue that arterial flow is compromised. Delayed capillary refill or absent pulses requires urgent vascular evaluation. Key action: document clearly, report quickly, and escalate early. Systemic signs mean the body is struggling. Don't wait for confirmation, act on suspicion. Some complications don't just delay healing, they can escalate into medical emergencies. Let's dive deeper into two of the most critical: osteomyelitis and dehiscence/evisceration. Osteomyelitis, a serious infection of the bone, often starts with chronic non-healing wounds, especially over bony prominences or post-surgical areas. What should raise your suspicion? Persistent drainage from the wound that doesn't resolve. A positive probe-to-bone test. If a sterile instrument touches bone, be alert. Presence of deep sinus tracts or tunneling. These often connect to infected bone. Elevated inflammatory markers like ESR and CRP, labs that reflect chronic infection. Imaging such as MRI, which detects early bone changes, or X-rays for chronic signs. And remember, the gold standard is a bone biopsy. Management typically requires 4 to 6 weeks of intravenous antibiotics, surgical debridement, and coordination with infectious disease, radiology, and wound care specialists. Now, let's talk about dehiscence, a post-operative wound complication where surgical edges split apart. It's often preceded by tension, swelling, or infection. The patient may report a sensation of a pop. Even more critical is evisceration, where internal organs, often intestines, protrude through the wound. This is a surgical emergency. What to do? Stay calm. That's the first rule. Immediately apply sterile saline-soaked gauze to protect exposed tissues. Keep the patient in a low Fowler's position. 2. Reduce pressure on the wound. Call the surgical team urgently. These scenarios demand both clinical skill and emotional control. Your quick thinking can save lives. Let's examine hypergranulation, a surprisingly common but often misunderstood wound complication. It presents as red, beefy, moist tissue that rises above the wound bed, like a mound. Though it may look healthy, it actually hinders healing by blocking epithelial cell migration. Common causes: excess moisture, often from overuse of occlusive dressings; friction or trauma to the wound bed, particularly in mobile patients; improper dressing techniques. Management strategies include switching to less occlusive, moisture-managing dressings, applying mild compression or protective barriers. If needed, silver nitrate sticks may be used to chemically cauterize the excess tissue, but only with proper training. Now, when should you escalate or refer? A wound that hasn't improved by at least 30% in 4 weeks needs specialist evaluation. If you suspect osteomyelitis, initiate labs and refer to infectious disease and radiology. A low ABI, ankle brachial index, less than 0.5 or absent peripheral pulses calls for urgent vascular referral. Rapid progression of necrosis, tunneling, or systemic symptoms, fever, confusion, hypotension, requires escalation to surgery, emergency, or hospital care. Never delay referrals when signs suggest deeper or systemic involvement. Time is tissue. Nurses are the frontline guardians in wound care. You don't just apply dressings, you assess, document, educate, and advocate. Here's how you make the difference. Monitor closely and consistently. Take note of wound size, color, depth, exudate, odor, pain, and changes in the surrounding skin. Document precisely. Incomplete or vague notes compromise continuity and legal protection. Communicate changes proactively. Don't wait for a physician round. Speak up when red flags appear. Reinforce fundamentals. Pressure offloading, hand hygiene, and nutritional support are not optional. They're foundational. Empower your patients. The more they understand their role in healing, the more likely they are to comply. And finally, collaborate. Wound healing is rarely a solo job. Work with dietitians, physical therapists, social workers, and specialists. You are the eyes, ears, and hands that spot trouble before it escalates. Patient education isn't just a nice add-on, it's a critical safety tool. Most wound complications happen outside the clinic, so patients and caregivers must know what to look for. Teach them to recognize signs of infection, increased redness, swelling, pus, odor, or pain. Follow dressing change schedules and how to do it cleanly if they're doing it at home. Avoid trauma or pressure to the wound. This includes tight clothing, sleeping positions, or poor mobility aids. Maintain nutrition. Protein, vitamin C, and adequate hydration support tissue repair. Track changes, a photo log with dates, can help detect subtle progression or regression. And above all, report concerns early. A quick phone call can prevent a hospital admission. When patients understand what's at stake and what's expected, outcomes improve dramatically. As we've seen, wounds can take a turn at any moment, especially in vulnerable patients. But complications don't have to mean catastrophe. Your vigilance, knowledge, and actions are what stand between a healing wound and a deteriorating one. Remember, look for red flags, local and systemic. Act fast, don't delay escalation or referral. Support your patients with clear instructions and encouragement. And work as a team. Healing happens faster when everyone is aligned. Every wound tells a story. Your job is to make sure it's a good one.